Okay. Good morning, Mimi.
Good morning.
Nice to see you.
Thanks. You too.
Mm-hmm.
Are we missing? What? We're not missing F.
They'll be here in a second. Let me look at that one.
Morning, Evelyn. Good morning. I'm not used to beating you, Evelyn.
I'm futzing around this morning, you know, doing my thing.
Look, Rhonda beat us both.
She did.
She must have had an early wake-up call.
Right.
She's got kiddos, little kiddos.
Yeah. So are you guys ready for today?
What we gotta be ready for? What happened?
Oh, nothing crazy, but let me just do this here. All right. So let me first things first. I am recording. All right, perfect. So let me just talk about the format for today. I actually have you guys until 1 p.m. I don't know if you know that. It's from 8 till 1. From 8 till 1. What I want to do is this. So I do want to spend a couple of hours going through these chapters. There's only 2 chapters. I want to spend a little bit of time talking about the exam for next week. I also want to, within that time frame or a little bit beyond, is do your one-on-ones, okay? Based on the fact that practice HESI, things of that nature, I have to do a one-on-one with each of you today. Get that done. The first thing, I did see your text about not being able to register for the final. Is that the case for all of you? Because I thought what we would do is go through it as a group and make sure we can all register. And if not, then obviously there's a problem. So I thought that was something I want to do as well. Okay. I do want to do a little bit of dosage calc. Okay. And I'm going to do a couple of join my quizzes based on the chapters that we're talking about. And I know we did that case study about diabetes, so it sort of gave you a little bit of an idea of what we predominantly are going to be discussing. Okay. First of all, any other questions? I know, as I say, there was a question about registering for the exam, but I thought there was some other concern if I look at. Can't hear you, Evelyn.
I just tried to register and I can't. It's saying an error scheduling exam.
That's what happened to me too.
Okay. Okay. I will get that rectified. And I'll get on there and see if there's something I can do. Probably isn't. I have, just FYI, I have asked if we can have a little bit more time for the final. I think the practice HESI was difficult. We only had 1.5 minutes per question pertaining to dosage calc. And I do want to talk about remediation as well. So, okay. So first things first, let's just talk about that exam. Has anybody had the chance to look or think about that exam and find areas that they feel they really as a group?
I looked at it that day.
Mm-hmm.
But after that, no, I didn't. Cause like I'm not
Okay.
being funny. I'm just not. Is that gonna be on my final? Because if it's not, then I'm not focused on that. I feel completely. I mean, I guess we'll just talk about it on the one-on-one. But I don't feel like I need to go back over that exam. Is that gonna get me to pass this class or not? Because we had that class last
There's
time.
always going to be dosage. There's always going to be dosage calc. Always. Now, there may only be about three or four dosage calc questions. There will always be dosage calc. So one of the issues I know that you brought up, Amy, was understanding when it says number only or numerics only, you don't need to put the milligrams per mil in, but of course the numbers pertaining to, is it, 10 or whatever, you do need to put that in, those types of things, okay? There will always be dosage calc, but as I say, it depends on how much dosage calc there will be. Have all of you received in your emails a remediation packet, meaning these are the areas? Did you all use your Concord email? Remember I said you have to use your Concord email.
Not yet.
What do you mean, not yet?
I didn't
What
get
is
no
that?
email.
Did you, when you registered for your exam, did you put your Concord email in? You did, all of you
Didn't
did. 'Cause
register.
Okay. So interesting.
It's my remediation's there. I just didn't do it yet.
Okay, so it did come through to your email.
Yeah, and I can see it if I go into evolve into that HESI, into the evolve. If you go into where we sign up for the test and you hit remediation, it's there.
Okay. All right. So let's do this because I want to make sure you guys all have that first. Okay. So if you could all go to your Elsevier logins, and I want to make sure that you all have remediation. And there's two reasons that I really want to make sure you have that.
Once you go in, you have to also, once you get your remediation up, you have to hit essential 10 because it's not showing all of them. And then recommended, mine says 18. I had to click that on to get all 18 little tiles.
Okay, go where now?
So go back into your Evolve.
Okay.
Go to your HESI assessment next gen tile.
Turn your background noise down, sweetie.
Kaylin, can you, whatever you've got going on in the back, and please turn it down or off. Thank you. So in your account, is that where you went to, the original, the HESI assessment next gen?
Yes.
Yeah.
And then you said essential remediation.
And then hit remediation. If you look on the left-hand side,
Mm-hmm.
it says remediation. Click on that. And then look, it's going to show the ones from last term, but scroll down and it'll show this practice September 15th one. And where you see the little blue essential 10, click that on it and it'll show all 10 tiles. Those are the ones that we have to do.
Yes.
And
Wait,
then
Evelyn,
and
you're
then
going too fast. Evelyn, you're going too
I'm
fast.
sorry.
All right, so listen, you said it says September because all mine say August, and I'm at the bottom. It says August 20 to 21.
You're in remediation, honey?
Oh, yeah, practice September 15th.
Yeah.
Yeah.
And then click on that essential 10 and it'll pull up all your 10 little ones you have to do. And then if you go scroll down a little further, it says recommended. And if you click on that, it'll show all your recommended.
It's not clicking on that phone though. Golly, jeez, computer.
Yeah, it's a
Slow.
little bit essential.
Because we're all on it.
So we just have to do those 10.
Well, here's the thing, Kaylin. None of you did particularly well on this, right? Realistically. So what do you think? Do you think it's wise to just do the essentials, or do you think it would help you to do the recommended as well? And I'm not being smart. I'm just
It's
telling it like
22.
it is.
It's 20. Listen, man, Miss Fletcher.
I
It's
know.
I'm so tired of. I'm so
It's
tired.
31. It's 31 in total.
Mimi, let me just answer Kaylin first. Kaylin, what do you say?
I mean, I don't know. I guess.
Well, here's the
Are we
thing.
gonna have pharmacology next term too?
Exactly.
Well, let's just, so here's what I would like you to do. Definitely do the essential packets. There's 10 essential packets, okay? I need you to do those. The other piece that is necessary is you've got to get a 78% or higher on your essentials. That is something that you need to do. 78% on your essential packets.
And you can. I guess you can keep taking it over and over again.
You know.
No, you can't. Okay. So when you fail it, then what happens? So because you don't get the 78, you fail the class? Because this is the concern.
Take your time. Take your time. The remediation is there for you to take your time. It's not like it's timing you. Take your time.
I'm about to drop out of this school. Y'all are y'all doing too much. I'm done. I ain't got nothing else to say for the rest of the time. I'm done. I'm quiet.
Okay. But that is part of the syllabus. It's actually in the syllabus. Okay? So bear that in mind. Don't rush through the essential packets. Take your time with the essential packets. And, you know, I'm asking you to get 78% or higher. So that's, now I'm being lenient. A lot of the others are asking for a lot more than that. They're asking for the 78%, but they're asking for other pieces as well. So I'm just pushing you guys to the next level because this isn't going to get easier, unfortunately. Okay. All right. And what I'm going to do today is on your one-on-ones, I'll go through each of your exams in the area on your one-on-ones. Okay. All right. I know it's frustrating, Mimi. I get it. I get it. I don't know what to tell you, but this is something that they're wanting from you. And I'm not even asking some of the other stuff that some of the other instructors want. I'm asking for this 10 essential packets and 78%. That's it. Okay. Now, it does need to be done before your final HESI. So you don't have to rush and do it all right now. Take your time, absorb it, do it slow, but it needs to be done for your final HESI, okay? So, and what I want to do with you, as I say, one-on-one, is go through things, look and see the areas that are maybe a little bit of a stumbling block for you. Okay, so we're going to do that after we've gone through these chapters. As I say, I want to do a little bit of join my quiz, to consolidate. I also want to do a little bit of dosage calc, things like that. All right. But I'm just letting you know ahead of time what the expectation is. And this isn't my expectation. This is a school expectation. And it is in your syllabus, talking about 78%. I'll have to find it for you, but it is in there. And I will. All right, take a breath. So let's turn to chapter 61, please, in your books. Okay. There's only 2 chapters today that we're going to go through. I'm going to talk about the endocrine system, one of my favorite things to talk about, actually. I think it's very underrated. I think that people realize the importance of the endocrine system. So on page, let me see, 1, 2, 3, 4, it says the purpose of the endocrine glands is to secrete hormones. And I would highlight this because it helps you understand exactly what it's all about. They're the natural chemicals that exert their effect on specific tissues known as target tissues. Okay. So when we look on page 1, 2, 3, 5, it shows a picture of the body, and it shows the pituitary, the thyroid, the pancreas, the ovaries, testes, adrenals, and the parathyroids. These are our target glands that the body is, that the hypothalamus, for instance, is saying, hey, I need you to secrete more of this, that, or the other, or hey, I need you to stop secreting this, that, and the other. Next to it on table 61.1, there are the glands, and then it shows the hormones. And really this piece of it is one of the most important things I want you to know. There will probably be questions related to, and I'm telling you for week 9, remember we're going to go through endocrine, diabetes, and last week as well. So bear in mind, you might want to know what is secreted by the anterior pituitary and what is secreted by the posterior pituitary. Most of it is secreted by the anterior, such as TSH, luteinizing hormone, follicle stimulating hormone, prolactin, growth hormone. All of these pieces are important, okay? And how does it work? It works through what's called a negative feedback system. And we've talked about negative feedback systems before, haven't we? Can anyone give me an example of one that we talked about? One to do with the kidneys, for instance? Anyone remember?
Isn't it just the opposite action?
Well, remember we talked about the renin-angiotensin system, how that feedback works, where you've got your antidiuretic hormones, those types of things, remember? You may or may not remember, but it's a feedback system. I'm going to go into more detail about it.
Okay.
Okay. So at the bottom of 1, 2, 3, 5, it talks about the fact that this control of hormone synthesis is a negative feedback system. So basically what happens is the hormone causes the opposite action of the initial change. Right. And on page 1, 2, 3, 6, it shows a nice little example at the bottom here. Here's an example. An example of a negative feedback system is insulin secretion. So blood levels start to rise, right? And the says, hey, pancreas, you really need to secrete some insulin. So the pancreas secretes some insulin, and then the blood sugar goes down. And so it's a negative feedback system. The action of insulin, which decreases the blood sugar, is the opposite of negative feedback system. The negative feedback system is that action of, hey, we've got to drop this blood sugar right now. And then, so the opposite of it is a condition that stimulated insulin secretion. It sort of had a response to that insulin secretion. Let me give you an example, for instance, with the thyroid. Many people take medications for their thyroid, right? So what happens is you have an increase in the thyroid stimulating hormone because it's stimulating the thyroid gland to make more T3 and T4. It's saying, hey, wake up, thyroid gland. You need more thyroxine on board. All right. You haven't got enough. It's a feedback system from the hypothalamus to say, can you please make some more thyroxine? That's a feedback system. That's what's going on there. And then it balances by saying, great, you've got enough. I'm sorry, let me close that door. I don't know if you could hear that noise or not, but probably could. So it's a feedback system. Another one, cortisol. All right, cortisol, which I know all of you have an abundance of right now, is secreted by the adrenal cortex down on page 1236. And it's showing you a lovely little feedback system of cortisol. So the adrenal cortex stimulates the secretion of corticotrophin releasing hormone in the hypothalamus, all right? The corticotrophin releasing hormone stimulates the anterior pituitary gland to secrete adrenocorticotrophic hormone. It's a process. One stimulates the other, stimulates the other, stimulates the other. And then when you release that cortisol. So Mimi, just now I'm using you as an example, us talking about the stress basically of having to do these essential packets is a stressor, just like anything else is a stressor, whether you're being chased by a lion or whether it's, oh my gosh, I've got to do this extra piece or whatever. It stimulates your body to secrete cortisol. That's what it does. And that's why we get this adrenaline. That's why we get, all of those stimulus that happens, okay? You release that cortisol, and the rising blood levels of cortisol then inhibit that corticotrophin releasing hormone. It says, okay, great, we've got enough cortisol on board. Hey, body, hey, adrenals, you don't have to secrete it. That's that feedback system. It's a loop, okay? And it goes on and on and on and on. And it just maintains that homeostasis because you really don't want too much cortisol on board or too little cortisol on board, because cortisol is what we need to live ultimately. So the hypothalamus basically is beneath the thalamus, hypothalamus, right, below. The hypothalamus shares a small circulatory system with the anterior pituitary gland. So you've got your hypothalamus and then the pituitary. And this whole system is, I know it as the HPA axis, or hypothalamus hypophyseal portal system. It's this downstreaming that goes on. In response, it says a bit further down, in response to releasing hormones of the hypothalamus, the anterior pituitary secretes some hormones that stimulate other endocrine glands. Okay, so for instance, the hypothalamus tells the pituitary, anterior pituitary, hey, you need to stimulate the follicle stimulating hormones. Those ovaries to start stimulating FSH. All right, or it's going to say to the testes, you need to start secreting, let's see, what do we got? Testosterone. Or it's going to say to the ovaries, you need to start secreting estrogen. All right, again, it's that feedback system that's going on constantly, and it is confusing. I have to sort of have it as a picture in my brain, and I have to sort of work that process through to understand how that works. And when you think about it, this is why our poor body is getting to so much trouble, because when you don't have that feedback system working effectively, that's when we have issues like endocrine issues, right? And some of them, for instance, hypothyroidism is a perfect example of that. That's a good example right there. So some of the hormones, I want you to be aware on table 61 too, pituitary hormones. Basically, the anterior pituitary hormones are everything but vasopressin and oxytocin. So the only two in the posterior are vasopressin or antidiuretic hormone and oxytocin, and it talks about it right there. Oxytocin, by the way, this is just an aside, and it might help you remember oxytocin. A lot of women, as they age, and I'm just helping you trigger something here, have an issue with libido. And, you know, I do functional medicine. So one of the things that we do is you can actually produce a little tiny pest that goes up into the vagina, and it's oxytocin, and it actually helps with libido. Just an FYI. All right. So you know, I'm just telling you this as an aside because it might help you remember about oxytocin. Oxytocin, trying contractions and ejection of breast milk, but it also helps with libido. So I'm just helping you store some little nuggets in your brain that you might remember. And remember, that's posterior along with vasopressin. Everything else is anterior. Predominantly on the test, it will probably be, if there's something about the pituitary, it's probably going to be an anterior. Okay, just FYI. All right. So be aware of the gonads. So it says here, and it's quite interesting to me, the gonads are the male and female reproductive glands. The male gonads are the testes, and the female gonads are the ovaries. And the function is dormant until puberty, right? And then under the influence of gonadotrophic hormones, secreted by the anterior pituitary, that's when you get maturity happening in puberty. Okay, the testes stimulated to produce testosterone, like ovaries stimulate estrogen, and that's on page 1237. Now, one of my favorite topics to talk about is the adrenal cortex, the adrenals. Again, cortisol, you got to have it for life. It just is what it is. The main hormone types secreted by the cortex, adrenal cortex, are mineralocorticoids and glucocorticoids. Mineralocorticoids are produced and secreted by the adrenal cortex. They help with fluid and electrolyte imbalance. And one of the biggies is aldosterone. And I know we've talked a little bit about aldosterone before. We've talked about how aldosterone basically manages water and sodium absorption and secretion. Okay, and remember I just said as well that feedback system, talks about it here, the renin angiotensin system. So that's all part and parcel of it. And then if we go down a little further, it talks about glucocorticoids, and that's also in the adrenal cortex, and they are essential for life. The main one is cortisol, like I just said. And you may bear this in mind. When our cortisol is high, and it talks about what cortisol affects, it's the body's response to stress, everything, emotional stability, immune function, sodium and water balance, carbs, protein and fat metabolism. When I see a patient come into my office and they say to me, I have all this extra weight around my middle and I can't get rid of it, it's cortisol. That's what it is. Okay, when they look like an apple, it's cortisol. So it talks right here, the functions of glucocorticoids hormones on table 61.3. I would make a note of it, okay? It has an anti-inflammatory effect. It prevents hypoglycemia. It maintains cardiovascular muscle management, responsiveness, on and on and on. Cortisol also helps with epinephrine and norepinephrine. Like I just said, when your cortisol goes up, those neurotransmitters, the excitatory neurotransmitters are implicated, okay? And just to let you know as well, here's something that I think you might find interesting. Your body can't keep pushing out a ton of cortisol. Eventually you get into what's called adrenal fatigue, and your body spirals down because you can't keep producing that amount of cortisol. So just bear that in mind. It talks about here, glucocorticoid release peaks in the morning. Why do you think it does that? Why do you think we have this spike of cortisol in the morning? Any idea? Anybody? Don't all shout at once.
Due to, because you rested, because you slept and you
Yeah.
rested.
Yeah. How do you think you get up in the morning? Cortisol. The reason we have this spike is to help us get up. All right. So when I do labs on people, I want to see that, or I'll do salivary tests. I might do a 24-hour saliva test on somebody, actually, and I'll see it spike. It's supposed to do that, and then it's supposed to drop. That's the whole point. When people have things like adrenal fatigue or they're running on empty, I might see an inverse type of situation. All right, let's look at this. Sex hormones, androgens and estrogens, they're secreted by a low amount of the adrenal cortex. As we get older and our testes and our ovaries give up the ghost and we go into andropause and menopause, it's actually the adrenals that take over and just secrete a little amount, by the way, with your sex hormones. All right, adrenal medulla. It's a sympathetic nerve ganglion. It stimulates the sympathetic nervous system and it causes the release of adrenal medullary hormones. The catecholamines, that's your epi and your norepi, all right? And it says at the top here on table 61.4, these tables I've sort of just highlighted. Bear in mind what it works on, because remember what the catecholamines do, right? So if you've got your epi and norepinephrine, it increases that heart rate. It causes vasodilation. The eyes, dilation of the pupil. All those things, those are the responses to that rise in cortisol, like I was just saying. And so your body isn't very good at telling the difference between what it's responding to. It's just responding. So we may need to take things to help us. And just to help you a little bit, it's an aside. This is why people on adrenal support. This is why I utilize in my practice a lot of things like B vitamins. I utilize a lot of things like ashwagandha, ginseng, rhodiola, lemon balm. It calms that system down. And you guys, all of you probably need it, quite frankly, with everything you're going through. And there's different ones that I use. I also use adrenal extract for those people that are so flat that they're like, I can't get up in the morning. I cannot even function anymore. So I'll put them on some pieces like that. We're going to talk about that in a minute. All right. So bear in mind the catecholamines, what do? They cause that fight or flight reaction, right? But your body just can't keep doing that all the time. At some point, it's going to crash. That's what happens. So the thyroid gland, where's your thyroid gland? Anybody point to it? Anybody know where it is? Rhonda, Kaylin, Elisa, show me your face. Show me where the thyroid gland is. Where is it?
It's right in there.
Thank you. All right. So it says right here, and it's got a beautiful picture on it on page 39. T3 and T4 is what is secreted. What is T3 and T4? It's actually the iodines. There's 3 iodines is T3 and 4 iodine molecules is T4. Okay. Parafollicular cells produce thyrocalcitonin. That helps our calcitonin levels. Okay. And what really happens with your thyroid? Why do you think so many people say, I put on weight, my thyroid gland isn't working properly? Well, guess what? It controls metabolism. That's what it does. It also helps with controlling cold temperatures, things of that nature. That's why people tend to feel cold or hot, depending on what's going on with the thyroid gland. Secretion of T3 and T4, again, like I just said, it's the hypothalamic, pituitary, and thyroid axis. The HA axis causes this negative thyroid system. So thyroid releasing hormone triggers the anterior pituitary gland to secrete thyroid stimulating hormone, and it stimulates the thyroid, just like I was talking to. Cold and stress are two factors that cause the hypothalamus to secrete and stimulate TSH. And just below it on page 1239, one, there's a lovely picture of the thyroid gland, and two, table 61.5 shows functions of the hormone glands, what thyroid hormones. Does a lot of different things, many. And I love using thyroid medication on patients. What's called euthyroid. At the bottom of there's a figure here, 61.6, and it shows the combination at the bottom here of what calcium does. Again, we're looking at these negative feedback systems. So it shows kidneys. It activates vitamin D. Believe it or not, they're now saying, and probably in a couple of years, you might see it in the books, that vitamin D is actually a prohormone. That's what they really think it is. It increases kidney absorption of calcium. So, and what does calcium do? Well, that helps our bones formation, right? It helps prevent bones breaking down, fractures, all of those types of things. Also be aware in the GI tract, there's an uptake of calcium and phosphorus from the gut via activated vitamin D. So vitamin D, remember vitamin D and calcium go together, right? When you go to drink you'll often see it says has vitamin D in it. They work together. Again, what do you think's going on there? Vitamin D is working like a hormone. Yeah, makes sense. That sort of connect with you a little bit. They class it as a hormone because it is. All right, at the top of page 1239, again, it talks about here calcium and phosphorus balance. It talks about the response to calcitonin. Again, that's produced in the thyroid gland. Calcitonin lowers calcium levels. It reduces bone resorption. Bone resorption is the release of that minerals. And depending on what's going on, okay. Let's see. I'm sorry, Miss Minwar just texted me. I apologize. Its actions are the opposite of the parathyroid hormone. So anyway, it says the serum calcium level determines calcitonin secretion. And remember I talked about calcium levels? Again, it's a very narrow window, a little bit like potassium, right? Narrow window where it can quickly be high or low. And the body's going to respond to that calcium level, whether it secretes calcitonin or not. So just be aware of that. The parathyroids. Talked a little bit about parathyroids with you when I said about tetany, okay? The parathyroid hormone regulates calcium and phosphorus. PTH, parathyroid hormone, increases bone resorption, which is bone release of calcium into the blood from bone storage sites. It increases calcium serum levels, okay? And that's fine, but then the calcium serum levels are going to go up and the body's going to respond to that. It says serum calcium levels determine PTH secretion. Secretion decreases when serum calcium levels go high. Again, this inverse goes on, and it increases when calcium levels are low. Pancreas. All right, pancreas. We have what two types of functions happen in the what two types of functions are there? It's at the bottom of page 1239. We're really only going to talk about one today, but I want you to be aware that there are two. Anybody tell me? Text me? Shout it out?
Glucagon and insulin.
That is true. That is an endocrine function, but there's two big functions, exocrine and endocrine, okay? So yes, Evelyn, you're right. Those are endocrine functions. I just want you to be aware of the two types. The exocrine function involves secretion of digestive enzymes, okay? But we're really going to talk about what you were just saying, Evelyn, the endocrine function. And it says the cells in the islets of Langerhans perform the pancreatic endocrine functions. And we have secretion of glucagon and we have secretion of somatostatin, right? And of course, insulin as well. So glucagon is a hormone that increases blood glucose levels. Okay, and insulin is the movement and storage of carbohydrate, protein, fats. That's what it does. So glucagon helps prevent hypoglycemia, and insulin helps to lower those blood glucose levels. It helps with the movement, and this is important because remember what I was talking about with type 2s versus type 1s. So if you get this in your brain, that basically what insulin is doing is to pull glucose movement across the cell membranes into the cells of many tissues. So I always think of it like a little truck, and that's what it's doing. It's saying, come on, let me help you utilize what you've got going on here. Some of the things that we need to be aware of with our older patient, right? Endocrine changes with the aging patient. So what are we going to do? What are some of the things, please, on 1241? Rhonda, give me an example of some of the changes. It's on page 1241. I do hope you're listening. You can text it. Okay, I'm going to take it that you're not listening. Elisa, I can see you. So I'm going to pick on you.
A decrease in ADH or antidiuretic hormone production.
Yeah. So the urine is going to become more dilute. Patient could become more dehydrated, right? That's a potential thing. Okay. Let's see. What else? What else happens? You don't have to. Let's see. Kaylin. Kaylin, where are you? Maybe something happened to her computer. All right, no, Kaylin. Okay. Evelyn, give me something else on page 61.6 that could happen with older people with some of the changes, or one of the changes.
Decreased metabolism.
Mm-hmm. And look at this. This is what I find really interesting, just FYI. Look at what it says about decreased production of estrogen. Look at all, now I know the issue with estrogen. Estrogen has, or estradiol actually has 400 functions in the body. So when people say, well, people don't need, you go through menopause and people start having problems, right? And this is one of the subjects I know a lot about. This is what I do. Look at all the different things. that happen. Just for an example, the vaginal tissue. That might not seem a big deal, but you think about this. Incontinence happens because the urethra is in a different position. Cystitis can occur, different things like that. It's a big issue. It may not seem like it is, but you think about it. Skin is thinner, drier, and greater risk of injury. Bone density loss. These are just simple things, but just think about it. If your collagen is reduced, it's not just about your face. Think about all of your vessels. Think about internally the intima of your vessels, right? If that's reduced, why do you think there's an increase in heart issues? Because your internal organs, your internal areas become drier, less flexible, more at risk for breaking, on and on and on. It affects your whole body. So just bear that in mind, okay?
I have a question for you.
Yeah.
With the estrogen, what, I know you're not giving Premarin.
Hell no.
Hell no is right. And I agree. But what are you, so you have a patient who has a problem with their estrogen. What are you doing for it?
Yeah. So I tend to, depending on what's going on with the patient, I'll do various things. So I know this is a little bit of an aside. I put them on what's called bioidenticals. I tend to do creams. I never give oral estrogen. The only time I would give oral estrogen is control pills to a younger person. Anybody older, let's think about this for a second. What's one of the big risks with birth control pills?
Blood clot.
Thank you. Okay, so and over the age of 35, isn't that more of a risk?
Mm-hmm.
Yes.
Okay, so why would I give that to an older person who is reduced, they have no estrogen, right? So they're already becoming a higher risk for cardiac disease, atherosclerosis, which is one of the big issues. And I'm going to give them an oral estrogen? No, I am not. So I might do a transdermal patch. I might just give it locally to the vagina. I may give a cream. Those are the big ways that I give estrogen. And I never give estrogen by itself. I always give progesterone along with it. Does your body just make estrogen? No. It makes progesterone, right? You got to balance. Just like we're talking about hormones here. You always want that balance. We're always striving for balance. Interesting, eh?
Well, I just, because I know my mother was on the Premarin, and she ended up getting breast cancer. She's fine now, but we believe that tumor grew within 6 months. She had a mammo. It grew within 6 months. And they didn't see it until 6 months later. She always had a problem, but
well, we'll talk about that.
We believe it grew because of the estrogen.
Yeah, and that could have been the case. And again, she probably was on unopposed estrogen. It's one piece.
Exactly.
Yeah. So tacking onto that, we're looking at on page 1240. It talks about people's genetics, genetic risks, all those types of things with the endocrine system. Okay, and I bear that in mind when I'm looking at my patients. A couple of things I want you to be aware of. Very important things: sleep, energy level, elimination, sexual and reproductive functions, physical appearance. All of these things are important, and that's why I say that endocrine system is sort of underrated. We focus a lot, of course, on the heart and lungs, but it's like grapefruit. I feel like the endocrine system is the grapefruit of healthcare, because people are always like, who cares about the thyroid and this, that, and the other? And I'm like, I do. So anyway, I'm just saying that people don't really understand it, this whole feedback system that goes on. So looking on page 1242, we're looking at all of the different maybe facial features. When someone comes in and they look puffy, they may have Cushing's syndrome. When somebody has what's called exophthalmos, any idea what that might be? And I don't think we talk about it too much, but bulging eyes. That is an issue with the thyroid. All right. So looking at certain things like prominent forehead or jaw, that could be what's called acromegaly. So lots of different things that when we look at a patient when I see a patient that they say my eyebrows are missing, the outer 2/3 of their eyebrows, if you're not going to see it, it's called Hertog sign. It's after a physician called Terry Hertog. But when I see that, that's a sign that somebody's got an issue with their thyroid. So we're looking at different things like hyperpigmentation, certain things with the adrenals, for instance, Addison crisis, they get hyperpigmentation, skin infections. You know for a fact you're diabetic, they're full of sugar, fungal infections, right, is an issue with them, things of that nature. Let's see, another thing to bear in mind, I want you to be aware of this, and you may see it on an exam. I don't think I've put it on an exam that I'm doing, but I just want you to be aware. It also talks about the melanocyte stimulating hormone, and we don't talk about that much, but again, that's another hormone. Some people get what's called vitiligo as a result of the hypofunction of the adrenal glands. It's caused by autoimmune destruction of melanocytes in the skin. So you see that, bear that in mind. That's an endocrine issue, okay? Certain things, adrenal excess, like I just said, Cushing's syndrome, you may see certain things like a buffalo hump, striae, hirsutism. Hirsutism, when I see it, I'm also thinking about things like PCOS, right? That can be an issue. Women who have PCOS, they secrete too much testosterone, and their blood sugar tends to be high as well. So all of those pieces I'm looking at, everything works together. It's a beautiful harmony when it works together, but when it doesn't, that's part of our role to look at it and go, how can I make this patient feel better? Or rather, that's how I think anyway. All right. We palpate the thyroid gland, don't we? And often we can ascertain that there's a goiter there. Sometimes we can actually feel that lump. We're checking for symmetry, that it moves, those types of things, that you can palpate it. Also as well that people, when I ask them, do you have a hard time swallowing? Some people might say yes. That could be a risk. That could indicate to me that there's a goiter, okay? It talks about thyroid storm on page 1242. Always palpate the thyroid gently if you suspect hyperthyroidism. Vigorous palpation, I would do that to anybody, can stimulate a release of the thyroid hormones and cause thyroid storm. They'll get palpitations and thyroid storm. We may have to get them into the hospital pretty quickly with something like that. Something else to bear in mind, and we just talked about this a lot because people don't really understand how much the adrenals and all of this reacts to stress. I have this happen a lot. Patients come in, they start talking, they appear somewhat normal. I usually have a box of tissues on my desk because after 5 minutes of talking with them, they normally break down in tears for one reason or another, mainly either they're stressed or they don't have enough progesterone, and I'm talking young women, or they've had a hysterectomy and they've been told, hey, you're fine, you've still got your ovaries, and they're not fine. So be aware of all of these types of things. Look at how you handle stress and look at how the patient handles stress, frequency of crying, degree of patience, anger expression. The patient may not recognize this, but to me or to you, that clues you in as to what's going on with that patient, and they could have some imbalances going on there. Lab testing predominantly, and you can do blood, urine, saliva test is a biggie. It says it right here. I'm so glad they finally are waking up to saliva testing. It tests the steroid hormones, like I just said, cortisol, testosterone, progesterone, estrogen, all of those things. So I'll sometimes do a 24-hour saliva test. They have to spit in tubes every few hours, things like that. It's a great way to tell what's going on. Provocation and suppression testing. Basically, what we might do is a provocation where patients might have an underactive endocrine gland, and we'll provocate it to see whether that stimulus occurs. And if it doesn't, then it's a really good example that, you know, that there's hypofunction going on. All right. On page 1243, it talks about blood testing. One thing to bear in mind, if somebody is on hormones dermally, please make sure that you've asked. You do not want them rubbing on their cream, then they're going to get their blood tested and the cannula inserted right where they've put their cream on. What do you think is going to happen? You think you might see an increase in that hormone when it's not really true? Urine testing. This might be on your test. Be aware. 24-hour urine testing. Have any of you ever had to do that on a patient or on yourself?
Yes.
What did you do?
They have to urinate, I think, in the morning. The first urine you don't collect, right? And then you start collecting for 24 hours.
Correct. Yeah. So it says here, remind the patient to not save the urine specimen that begins the collection. The timing is for the urine collection that begins after that. So they discard that first one and then they collect the urine. And please be aware of urine testing and what it says. You know, specimen needs to be kept cold. You know, make sure they write the time on there. It says it right here, and there may be a question for you on the test about this. Tell the patient about the preservatives and the need to avoid splashing urine from the container, because some of the preservatives make the urine caustic. All right, so be aware of those types of things. All right. Genetic testing, love doing genetic testing. Remind the patient that the urine testing is done for 24 hours. One of the urine tests that I do, Evelyn, to your point, is I might test somebody to see how the body metabolizes their hormones. Is it going down the right pathway or not? Those types of things. So I look at stuff like that. If somebody is a high risk, I might do that. Also testing for glucose. What's the big glucose test that we do to test for diabetes, other than a fasting blood sugar?
Where they drink the glucose, where they drink and they take the 3 different bloods.
That glucose tolerance test. What's the one where we look at a blood, what the blood's been doing over 3 months? 120
HA1C.
Hemoglobin A1C. Yeah. Correct. Yeah. Okay. Just to let you know, of course, we do imaging. We may do an ultrasound of the thyroid. We might do a biopsy of that thyroid, a needle biopsy, like it talks about if somebody's got thyroid nodules, to check for cancer. Of course, we can do CTs and we can do MRIs. And it says here, MRIs with contrast is the most sensitive test for the pituitary gland. So that's basically it for that chapter. Now, My suggestion is we don't talk about 62 and 63, but you may just want to have a little look through it. It's sort of a shame because those are my favorite things to talk about, but I do want you to at least look at some of the pieces, like it shows the increased pictures of the increased pigmentation with Addison's disease or adrenal corticotrophic insufficiency. There's a nice picture of somebody with Cushing's syndrome, things of that nature. So I would definitely look through it and just bear in mind what somebody looks like. You know, sometimes a picture is worth 1,000 words, right? For sure. So let's have a quick break before we go on to, where are we? Perfect, perfect, perfect. So I'm going to get you guys to do join my quiz. So take a breath. Up, join my quiz. It's only 10 questions. And you the code. Let me know when you're ready. How do you feel about your hormones now, guys? Let me know, seriously, if you ever want any suggestions on some supplements that could be helpful, please reach out to me. I'd be happy to help. There's some beautiful things out there that really, truly help people. I'm going to use one of my best friends as an example. You know, she's in her 50s. She works for a very prestigious organization that isn't really into all this stuff. Finally started to get things happening, like she's got Chazalians on her eyelids all the time, all sorts of things. And basically her doctor was like, yeah, well, you know, just basically managing the symptoms. And I said to her, look, it's a symptom, which means going on at a deeper level, right? So basically I've stuck her on a little bit of estrogen, a little bit of progesterone, 15 milligrams of Alma thyroid. And guess what? Within a week, she's like, guess what? I'm sleeping better. I feel happier, on and on and on. It's little. All right, are you guys all there yet? Will you join my quiz?
Yes.
All right. So it is going to be 193418. Where's the rest of you? Where's Elisa? What are you doing?
It keeps telling me invalid game.
Maybe you put the wrong number in. 193418.
There we go.
There you go. Kaylin, Rhonda.
I'm here. Hold on just a second. What was the code, Miss Fletcher?
The code is 193418. 8. Kaylin, where are you? Can anybody, does anyone know where Kaylin is? Where is Kaylin? Me. See, in some ways, this is why I think it will be good to be at school. Because at least that way, you know, if there's computer issues or other issues, you're able to concentrate a bit more. Does anybody know where Kaylin is? Or if there's an issue?
I don't.
Okay. All right, so let's see, what time is it? 9:05. Okay. All right, guys, we are going to do this quiz. It's just a hormone quiz. Simple, fairly straightforward. Let's start it and see. Number 10 is a silly question, by the way, but whatever. Wow, Mimi's firing ahead there. Okay. Just waiting for one more to finish. All right. I want to go over that a second. Questions. Okay. I don't know what happened to Kaylin. Can you guys hear me? Okay. So well done. Looks like, oh, somebody didn't. All right, but most of you got insufficient secretion of insulin causes what? Diabetes. What about this one? Renin and angiotensin. Well, I talked about that, right? It's secreted by the kidney. Yeah. Secretion of endocrine glands. If there's more than required, then it is called hypersecretion. What about none of you answered this, and I talked about this. Which gland secretes calcitonin? Chapter 61, page 1239.
It's the thyroid.
Yep. Yep. Did any of you put that in there? No. All right.
No.
All right. Hormone produced in the dark is what? I didn't actually tell you this, but anyone have a guess?
Melatonin.
Melatonin, exactly. Why you need your sleep, right? Melatonin is a anti-inflammatory. Hormone stimulating milk secretion is called what?
Prolactin.
Main target of enterogestrone hormone. Well, I didn't actually go over this one. It's probably intestine. The intestine or stomach, does it? Let me see. Stomach. Okay, oops. Where's my, how do I go back? Okay. Main target of parathormone. Talked about that. What does it do? The main target. Anybody? Did you all get it right? No, only one person got it right. Parathormone. Bone. Blood, bone, right? A mixed, I talked about this. I didn't call it a mixed gland, but I did tell you it has a couple of functions. Pancreas, yeah. And that's that. All right. Hey, gives you an idea of what you understood or not, yeah? So I am going to give you a 15-minute bathroom break. Let's meet back at 9:30, and we're going to go over this big chapter, because it is a big chapter, all about diabetes. Okay, so let's be prepared for chapter 64 in 15 minutes. Guys? All right. Thank you. Hey, Evelyn.
Hey.
I told you.
All right, I've still not heard from Kaylin. I don't know if something happened. Not sure what has gone on there.
Okay.
It's unusual for her. She's usually,
She was here too.
yeah, I don't know. All right, so chapter 64. Just to let you know, I did look at the syllabus. I think for the practice remediation, it doesn't, I know they're making a lot of changes with the remediation piece of it. Because your practice remediation does not state 78%, I won't expect 78% on your essential packets, okay? Just FYI. However, on your finals, you do need to make 78% on your essential packets and some. So I'm just letting you know. But on the remediation, just for the practice exam, you do not need to. I would suggest you sort of start gearing your brains up for that, because I know next term they're making a lot of changes. I don't know if Mimi, you can hear me, but if you can, just FYI regarding that information. Okay, everybody ready? Chapter 64. So this whole chapter is talking about diabetes, and I think we're pretty familiar as to what diabetes is, but basically, like I just said, you've got your feedback system between glucose and insulin. And it talks about the complications of diabetes. And I think it's important because, you know, why do we care if somebody's got high blood sugar or not? One of the reasons we care is because of the complications that go along with it, such as hypertension, hyperlipidemia, neuropathy, Alzheimer's, on and on and on, okay? So all of these issues that are related to blood sugar being elevated shorten people's lives. So that's why we care. So when it's on page 1281, it's a nice little diagram here of hypoglycemia. And I would suggest you sort of try and get these ranges somewhat in your brain, because definitely on your exams, there's going to be questions about hypoglycemia, what that means, understand where that range is, right? So that you know what you're going to do about it. Of course, a normal range and then hyperglycemia. So it talks about type 1, and I think we now understand that type 1 is an autoimmune, idiopathic type of thing. I see it a lot and hear about it a lot over and over and over again. Hey, I had a massive stressor in my life and bam, I developed type 1 diabetes. Of course, it happens to babies. It's a genetic component there. But I also hear about it from people that are a little older and something big happens, whether it's an infection or whatever it is, that really knocks the body and causes this cascade leading to type 1 diabetes. And type 2, why do we care about type 2 so much? Well, because it is preventable. I mean, it really is preventable. It ranges, as it says, from insulin resistance to those that have type 2 diabetes that then need to be put on insulin. Okay, and insulin resistance, if anybody isn't familiar with that term, basically what that means is the body is trying to pump out insulin because of the demand for glucose. And it gets to the point where it's like, listen, body, I just can't keep pumping out this insulin. So there's an insulin resistance going on, if that helps you bear that in mind. And then, of course, we've got gestational diabetes, which can occur, and then usually the body bounces back. And after the baby's been born, they're not diabetic anymore. All right. So the endocrine, pancreas, we already established. exocrine function, which is to do with digestion, endocrine function. There's the alpha cells secreting glucagon and the beta cells secreting insulin and amylase. And glucagon is a counter-regulatory hormone. It has the opposite effect on insulin. It prevents hypoglycemia. Talks about active insulin. And the reason I'm just bringing this out is because we're going to talk a little bit about it down the road. It's made up of a bunch of amino acids, but why do I care? Well, it says here a prohormone that contains an additional amino acid chain is the C-peptide chain. I care about that because it says proinsulin is converted in the liver to activate insulin by removing this C-peptide. When we test people for type 1 diabetes, this is one of the tests we do. We do a C-peptide to see whether they have it or not. And I'll go into that more a bit later. Insulin is secreted into the liver. It's secreted at low levels when somebody's fasting. And then they've just got this basal secretion going on, just this tiny amount of insulin pumping all the time. And then prandial, which is this burst of insulin that occurs after we've eaten, okay? Usually within 10 minutes of eating. All right. During fasting, when the stomach is empty, the glucose is between 60 and 150. And then other organs, it says, uses glucose and fatty acids to generate energy. I think that's fairly self-explanatory, right? Glucose is stored as glycogen in the liver and skeletal muscles, and free fatty acids are stored as triglycerides in fat cells. So you can see right here this interplay between the cholesterol and glucose, this interplay that's going on. During a prolonged fast or after an illness, proteins are broken down and some of the amino acids are converted into glucose. That's where we get this ketogenic effect going on. And at the top of page 1282, there's a nice little picture that just shows the pancreas, this proinsulin with the C-peptide chain that is important for that. The liver, the C-peptide chain again, insulin receptors, and then the target cells. So just want to give you a pictorial of what we're talking about. Insulin is like a key that opens the locked membranes to glucose. So it allows, like I've said many times, it's basically a truck, right? It's the little truck that carries this blood glucose to be able to move into the cells and generate energy. And that's what it does. Insulin starts its action by binding to membrane insulin receptors and changes membrane permeability to glucose. It exerts metabolic effects on the skeletal muscle, on heart muscle. It suppresses liver production of glucose and also the very low density lipoprotein. Again, this interplay between cholesterol. This is why when I look at the cholesterol, I look at things like the triglycerides. I look at the VLDL. I look at those things because they all interplay with somebody who is has insulin resistance or type 2 diabetes, and on and on and on. Various terms I just want you to be aware of, and they're all sort of very similar, unfortunately. We have glycogenesis, which is where insulin promotes the production and storage of glycogen. We have glycogenolysis. This is the breakdown of glucose. We have ketogenosis, which is conversion to fats to acids, and glucogenesis, it's the conversion of proteins to glucose. Now, you may or may not remember all of that, but I do want you to be aware of those key terms. Overall, insulin keeps blood glucose levels from getting too high and helps blood lipid levels stay in the normal range. Do you see that connection right there? That's why we care, right? Too much cholesterol, not necessarily a good thing, yeah? Again, it talks about the fasting state. insulin secretion is suppressed. We just have that tiny little bit of basal insulin going on in the background. It leads to this glucogenesis. And what did we say that glucogenesis is? It's the conversion of proteins into glucose. That's that ketone effect going on there. And it also it allows for increased glucose generation by the breakdown of liver glycogen. So there's a lot of things going on in the body to maintain this homeostasis, right? Another thing I want you to be aware of a little bit further down on 1282, and these are terms that are important for you to bear in mind when we talk about medications that are used, specifically in 2. This is one of the ones that I want you to bear in mind. Glucose in the blood after a meal is controlled by the emptying rate of the stomach. They're absorbed into the circulation. The incretin hormones, i.e. GLP-1, maybe we're going to see that as a medication that's used for blood sugar, is secreted in response to food in the stomach. It has several actions. They increase insulin secretion, they inhibit glucagon, they slow the rate of gastric emptying and prevent hypoglycemia. It also helps with weight control, by the way. This medication is used, this process, they looked at that and went, that would probably make a great medication for type 2 diabetes. And we will talk about that in a bit, but this is why I want you to bear these things in mind. All right, so bear in mind, if somebody has a blood glucose range of 60 to 100, their brain's not functioning a lot of the time. Maybe at 100, maybe at 80, yes. But when it gets down into the 60 range, you know, people aren't really, their brain stops functioning. I mean, that's why we need to give them something to raise, right? All right. Absence of insulin in diabetes can be a lack of production, a problem with the lock and key. That's more of the type 2. Those are the types of things that are going on. So high blood sugar, we call it hyperglycemia, right? What are some of the classic signs of diabetes? Anybody tell me on page 1283? The top of 1283.
Excessive thirst.
Mm-hmm.
Frequent urination.
Mm-hmm.
Eating.
Yeah.
Hungry. You're hungry.
Especially your type 1s. Yeah. Especially those. And we call it polyuria, polydipsia, and polyphagia. All right. So on page 1283, it talks about that. I would suggest you understand that, know it, learn those terms if you don't know it, okay? And at the top there on page 1283, that table just shows you those terms that I was talking about. Glycogenesis, glycogenolysis, glycogenogenesis, and I can't even say them, and then ketogenesis as well. All right, bear in mind those things. Ketone bodies, right? We talked about this the other day, about ketones, what they do. It's an abnormal breakdown, and please bear that in mind because I know people love the ketogenic diet. There's a lot of good things about it. There's a lot of good things about intermittent fasting, but it is an abnormal breakdown where the body is no longer using glucose, it's using the fat stores for getting its energy production. So bear that in mind. I'm not going to go too much into that. But of course, we see ketones in our type 1 diabetics with their DKA, and we talked a lot about that the other day. Dehydration leads to hemoconcentration, increased blood concentration, hypovolemia, hypoxia, of course. That all makes sense, right? Hypoxic cells do not metabolize glucose effectively. The Krebs cycle is blocked, lactic acid increases, And that way, this is what leads to that metabolic acidosis that we know about. And again, it talks about it a little bit here. So what does the body have to do? Well, this is where that Cozumel respiration comes in, where you're trying to blow off that excess carbon dioxide and acid. Okay, that's why that's happening. Acetone is exhaled. That's that fruity breath that is smelt. All right, that's what's going on there. Insulin lack initially causes potassium depletion. Remember how we talked about the combination, the sort of effect there between potassium and insulin? We talked about that, didn't we?
Frozen.
Sorry about that, guys. Am I back?
Yes.
Yeah. Okay. All right, where was I? So anyway, urine gets excreted, potassium gets excreted in the urine, so you get hypokalemia, and then of course, high potassium levels occur in acidosis because potassium gets shifted from inside of the cells to the serum. So we get this hyperkalemia. And of course, that's all related to dehydration as well. We talked about DKA, we talked about HHS, and then of course, we've got the other issue of hypoglycemia, okay? All of them can be fatal, we know that. Complications of diabetes. Well, let's think about this. What did I say the other day? It's like having maple syrup or sugar, you know, thick, gunky stuff going round and round in the body's vessels, right? Especially what areas? The microvascular areas. Give me an example of the microvascular areas. It's here on page 1283. Any examples? Microvascular areas.
Heart.
That would be macro. Did you say heart?
Yeah.
Okay. I would say.
Oh, you want micro.
Small blood vessels.
Yeah. The eyes, the kidneys, right? This is why we're looking at these things. This is why they're at risk for things like retinopathy. Yeah. Neuropathy, peripheral neuropathy, and of course renal neuropathy as well. So all of these types of things lead to hypertension, like I just said, different things of that nature. Of course, we mentioned the correlation between what was I talking about earlier? The cholesterol as well. All right, so what are we looking at? The hemoglobin A1C, right? For every percentage point decrease in a hemoglobin A1C, a 35 reduction of kidney and eye complications has been shown. So it's important that we get that hemoglobin A1C down to a level that is a normal level. Cardiovascular disease, it talks about there's more of a risk for women than men. There's also a risk depending on different ethnic groups as well. One of the things we measure is the albumin with these patients, because seeing protein in the urine, albumin in the urine, is not a good thing. That means the basically the vessels, there's leaks in the vessels, and protein is able to get out where it shouldn't normally be able to get out. Patients often have increased inflammatory markers like a CRP, okay? What else am I looking at? I'm looking at other risk factors: cigarette smoking, family history, sedentary lifestyle, obesity, on and on and on, right? On page 1284, it is also stating now about patients' blood pressure. We want a blood pressure below 140/90 for these diabetics. I would prefer a target blood pressure of 130/80. That's the recommendation. Lipid lipid screening, of course, is important. We want the LDL below 100. We want the HDL above 50. We want our triglycerides. I'm not seeing it right here, but I know we talk about it a bit later. Where am I? Where am I? Triglycerides. Bear with me, I will get to that because I know there's a triglycerides that we want reduced as well. Where is it? Where's my triglycerides? I will get to that. Anyway, we want all of those in range, right? We want the total below 200 as well. Different risk factors. Stroke, it's a big risk factor, right? They can not just, the carotids can become atherosclerosed. Immunity, white cell activity can be reduced. You've got this inflammation going on in the body. And remember, you've got sugar going on in the body, right? So what draws, what type of things? You've got the increase for bacteria, like I said, fungal infections, those types of things can develop more easily. That's why we're very cautious with our patients, making sure they don't get cuts, things of that nature. Like I just said, blindness, legal blindness is a high risk. Diabetic retinopathy, yeah. One of the things I want to draw your attention to on page 1284, proliferative diabetic retinopathy. What happens is the body always wants to restore itself. So it tries to produce these new blood vessels in the eyes. But the problem is the new blood vessels are not great blood vessels. They're very thin. They're fragile, so they can bleed easily. They can rupture and bleed easily, and again lead to vision loss. One of the things I want you to be aware of, and we talked about this when we talked about ears and eyes, but this diabetic retinopathy, it talks about the fact that the central vision is one of the key items that goes first, rather than the peripheral. It's the central macular degeneration that occurs. We talked about eye issues. So give me a couple of eye issues that we talked about generally that can occur with diabetes or with anyone. One of them, two of them.
Glaucoma.
Glaucoma, yes. What's the other one? Think about sugar that crystallizes. Looks a little bit like a what? Cataract.
Oh,
Yeah.
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 Yes.
If you think about sugar crystallizing, that's what's going on there, right? So it tends to occur with people that are younger. All right. Peripheral neuropathy. Well, I think you guys are somewhat familiar maybe with peripheral neuropathy. You know what I'm talking about? Yeah.
Yes.
They basically, what happens is the myelin sheath is damaged. We talked about that the other day. Again, blood flow is reduced. Excessive glucose collects in the nerves. And again, you've got this gunkiness that's gone. So different types of neuropathy, right? Fingers, toes. It can be an acute ischemic event, like I just said. It can be in the eyes. It can affect facial issues, double vision. One of the big things that I think that we don't talk about and is a big deal with these patients as well is diabetic autonomic neuropathy. That's a big long word, but basically what happens is the whole body is affected. So the sympathetic and the parasympathetic system is also affected in the body. They often can get orthostatic or postural hypotension and syncope. The body just doesn't respond quickly enough because of these vessels being damaged. It can affect the GI system. A lot of diabetics end up with small bowel issues, things like gastroparesis. Like I just said, my husband ended up with a small bowel resection secondary to the diabetes. It tends to lower the ability to the body for the body to do gastric things of that nature. So heartburn, nausea, anorexia, basically sluggish movement. Think about that, okay? So if they've got this sluggish movement going on in the small bowel, it's a thing called gastroparesis, just FYI. And it talks about it down here. Couple of other things, obviously urinary problems, kidney problems. I think that's fairly self-explanatory. But there's another couple of things that I want you to be aware with this autonomic neuropathy that goes on. And it's a term called anhidrosis. Very interesting term. Basically what it is they sweat differently. Now, those of us that have had a hypoglycemic episode, you'll sweat, right? You'll burst into like sweating. But a lot of the time as well, diabetics, they only sweat in certain areas, or they'll sweat too much in other areas. So, just bear that in mind, because of course that affects their skin, right? Skin breakdown can occur, or they can have very dry skin in certain areas as well. So it's sort of interesting to me. Well, to me, it is interesting because I live with a type 1. He's my test case. I'm like, oh, yes, you have this, you have that, oh, and you have this. Poor guy. Anyway, so diabetic neuropathy, nephropathy rather. Unfortunately, diabetes is the leading cause of end-stage kidney disease, stage 4. Many drugs are used to protect the kidneys. Anybody have an idea of a drug that could be used to protect the kidneys? It's on page 1286. ACE inhibitors or an ARB. And a lot of the time, diabetics are put on ACE inhibitors or ARBs, not because they're hypertensive, but actually as a protective factor. It helps kidney perfusion. All right. So, and it talks about it right here. We're going to be looking at the glomerular filtration rate. We're also going to be looking at microalbumin. So those are a couple of things that we're going to look at. Sexual dysfunction, well, I think that's pretty self-explanatory, right? It affects everything. So many men get erectile dysfunction. Many women experience issues, sexual intercourse, decrease in libido. It can affect cognitive function. That makes sense. Microvascular disease, Alzheimer's, right? Depression also. It can be depressing to have all of these potential things happen. And it talks about it right there. Type 1 diabetics, it's an autoimmune disease. And on the top of page 1286, table 64.4, it just differentiates type 1 to type 2. So that might be a nice little thing to just bear in mind, okay? They do look at the genetics of a type 1. Normally they're not overweight. Normally your type 1s, when they present, are hungry all the time, they're thirsty all the time, those types of things. They're not obese. Type 2, metabolic syndrome. I want you to bear this in mind. On page 1287, if you've never heard of metabolic syndrome, it used to be called syndrome X, same thing. But metabolic syndrome basically is one of those things. If somebody has metabolic syndrome, I'm looking at them and going, yep, you're going to be a type 2 diabetic. So let's look at it. There's several factors, 4 main factors. Abdominal obesity, the circumference of the waist is more than 40 in men, more than 35 in women. Hyperglycemia, blood sugars higher than 100. fasting blood sugar. Hypertension, blood pressure is more than 130 over 80. I'm sorry, more than 130 over 85, somewhere in that range. And then hyperlipidemia. Triglycerides are greater than 150. HDL below 40. I like that HDL high. Remember what I said, H for healthy, right? Low for lousy. Not saying you don't need both, but it's to do with the ratios. Again, with things like fish oil, we're looking at ratios, the differences between EPA and DHA, just FYI. What else? It does talk about incidence and prevalence. I'm not going to go into all of that. It's about different types of minorities that may have a higher rate of incidence. So again, we're looking at our patient, and we want to be advocates and make sure that we look at our patient and go, okay, these people might be at higher risk. All right. It's something I need to do as a nurse practitioner, but also it doesn't stop there. Look at that as nurses anyway, right? Health promotion, my favorite thing to talk about. So on page 1287, let's get into the fun stuff. Table 64.5. Look at levels. I would suggest you learn some of these levels to do with diabetes. Again, we're looking at hypertension. Some of the risk factors. Are they physically inactive? Certain risk, certain ethnic populations. Babies weighing more than 9 pounds. Hypertension greater than 140 over 90 or 130 over 85, depending on if they are pre-diabetic or not. Cholesterol, HDL greater than what? What did I say I want it greater than? Because I know you're listening.
50, 40?
I want it greater than 50, yes. When I see somebody lower than that, that's a risk factor for me. Triglycerides, if they're higher than 250. Hemoglobin A1C, if it's higher than 5.7. So all of those types of things are my ding, ding, dings of this person is heading down the road of type 2 diabetes, okay? Let's see. We talked about the lab values, and at the bottom of 1288, it shows the fasting blood glucose test, the glucose tolerance, and the hemoglobin A1C of what we're looking for. A level of greater than 6.5, yep, you're diabetic. Okay, anything below that? Anything below 5.7 is great. Between 5.7 and 6.4, you're heading towards diabetes. Okay. So I talked about the hemoglobin A1C, and I want to know if you know what that is. So at the bottom of 1289, can anybody tell me what that really means?
It checks your glucose over 3 months.
It does. Yeah, it's actually the lifespan of the red blood cell. On the red blood cell is obviously hemoglobin, but also glucose. So basically, as that red blood cell breaks down over 120 days, that glucose is on it as well. Okay, so that's what we're really looking at. So I want you to be aware of that. So the nice thing is, you know, they can't really get away with fasting for a couple of days and tell what someone's been doing over the past 3 months. Okay. Let's see. Oh, I did mention to you about some of the testing for type 1s, right? So we mentioned the fact that it is an autoimmune disease. There are certain auto antibodies that we can test for. One of them is a GAD65. It says that these islet cell auto antibodies basically are present in 85 to 90% of patients with new onset type 1 diabetics. So this autoimmune destructive piece, you're going to see that. The other thing you might see, maybe I mentioned the C-peptide levels. This is why I mentioned it. They always measure a C-peptide level. Low to absent C-peptide levels diagnose type 1s. And also bear this in mind, late stage type 2s. Basically, by this stage, the pancreas says, yeah, I've given up. I am not secreting any more insulin. You're done. Okay. Your BMI. BMI is an important piece that we're looking for as well. And if you didn't know what your hemoglobin A1C is, this is a nice little table on 64/7. Hemoglobin A1C, for instance, hemoglobin A1C of 6 means that the patient has had roughly a blood glucose of 126 for 3 months. Okay. On page 1290, a beautiful concept map. Love these concept maps. And you know, you may just want to make note of that because I think that's a pretty typical type of situation going on there. Shows her blood glucose level is high, the triglycerides, hypertension, and she's just a walking train wreck, right? Really. ADA says the hemoglobin A1C, they really want patients to get that hemoglobin A1C down below 7. That's the goal. Obviously, I'd like it lower than that, but that's the goal. We're doing anti-diabetic drugs, right? And we're also doing all of the healthy lifestyle things. I don't think I need to go into, really. Do I? Do I need to go into that? No. All right, so let's talk about these meds for type 2 diabetics. On page 1292, there's a lovely chart, 64-2, that shows, I mean, I think we've got about 7, 1, 2, 3, 4, 5, 6, 7, 9, yeah, 7 different types of drugs that we can utilize for our type 2 diabetic. And the first line med that's always going to be used is the metformin or biguanide, all right? It doesn't increase insulin, it reduces glucose production. So we're going to do that first. That's the biggie. And then, of course, we're usually going to add in some of the other pieces if that one didn't work. So we may add in a sulfonylurea, like glipizide, and we may even do a combination of one of the two, like Metaglip, or Metaglip is one that I know of. Let's see, there's Gluco, or Metaglip is one of the ones that I'm thinking, and that's a combo of the two. But basically, these are the ones that actually do help to lower glucose by triggering insulin. So what do you think we're going to teach our patient? They need to be careful of what?
Hypo.
Yes, hypoglycemia. Exactly. Then we have the thiazanolidazines, and I can't pronounce that very well. I don't see these ones used as much. Actos, they have a black box warning, and somebody who has things like congestive heart failure, they've seen that it actually makes it worse. So I don't tend to see these used as much as some of the others now. These other ones, the alpha glucoside inhibitors, anything that's an inhibitor, right? They prevent the after meal hyperglycemia. They help to inhibit enzymes that break down starches, and they basically just help it to go passing through the body. It says teach patients to take these drugs only with a meal because the action is in the intestinal tract. So if a meal is skipped, so is the drug. It's not going to be utilized. And that's, again, I don't know if I see these so much. Precose, Acaribos, has anybody seen that used that much? I don't see that one used that much. The next one I do see used, these next few. Remember I talked about GLP-1s, the incretins, and how that is utilized. Basically, these drugs, and this is the injectables. This is your Trulicity, your Victoza, those types of things that get used. And what they do, it's really clever because, like I said, somebody looked at this and went, huh, why don't we utilize this incretin? So these drugs act like natural gut hormones that I mentioned earlier that work with insulin to lower blood levels. They reduce pancreatic glucagon secretion, they delay gastric emptying, and that slows the rate of absorption in the blood. These are subcutaneous only, but they're not insulin. All right, so instruct the patient that this is not an insulin. And some of these are extended release. They can be given just once a week, just FYI. So you may see that being used. And let's see if there's anything I wanted to mention about that. No, I want to carry on. All right, then you've got your DPP-4 inhibitors, and this is on page 1293. Again, these are great. So, you know, a lot of people are like, metformin is great for weight loss, by the way, just FYI. Some people use it for that. DDP4 is an enzyme. Again, it breaks the natural gut hormones down, the GLP-1. DDP4 inhibitors, oral, as opposed to the other ones that are subcutaneous. They break down the enzyme DPP4. It allows these substances to work with insulin. It delays gastric emptying, just like I talked about with the subcutaneous version as well. But basically what these are oral, and they help to reduce blood glucose levels. This is the Tradjenta, Januvia, those types of things. And I've seen those used a lot, very, very nicely, like a once a day. But again, be careful, teach the patient that their blood glucose levels could drop quickly and they could become hypoglycemic. Okay. Let's see. A couple of things to be aware of with these types of drugs, and I think it's because it has this effect on GPL1 and also the incretin process. Of them can be concerning. It says increased risk for pancreatitis, so it isn't without its risks. Amylin analogs, Similan. This is another one that's subcutaneous. This one actually works. I'm just going to say these drugs are similar to amylin, a naturally occurring hormone from the beta cells in the pancreas. It's co-secreted with insulin, and basically it helps to reduce blood glucose levels by decreasing glucagon. So that's what it does. This one actually triggers satiety. What is satiety? Anybody know?
All I know is most women don't want to take that medicine for this group.
Yeah, well, I think I probably know why. But, well, look at this. Satiety helps you not to feel, satiety is when you feel full. So again, it's good for weight loss, potentially. But look at one of the big side effects. Nausea and vomiting. Not a good thing, right? Is that what you're hearing from people?
Yeah, I mean, I've heard that the Invokana is really a good medicine, but it has so many of the side effects for women that most women don't end up taking it for very long because it causes so many UTIs and yeast infections in them.
Yeah. So we're going to talk about that one next. That is your SGLT. or sodium glucose co-transport inhibitors. So yes, you're absolutely right. Invokana and Jardiance are great. Basically what they do is help to excrete extra glucose. That's what it does. That's wonderful, but as Evelyn pointed out, one of the biggest side effects is an increase, and it talks about it right here, predisposition of UTIs. So yeah, it's good. And also, of course, genital yeast infections as well with all that extra sugar. So this is a nice little chart that just shows all of the different ones. And basically a lot of it is different doctors tend to prefer different things. I've utilized myself. I'm always going to stick somebody on metformin first, see how they do with that. I might have to increase that. I may have to add some of these other ones in. I might do a once a day one of these incretins, or I might do an Invokana or Jardiance or something like that, or a Januvia, just depending on what's really going on with the patient and how they tolerate their meds. And we sort of switch things up and switch things around. But what I like about it is we're using the body and we're sort of looking at it and going, well, this works in the body. Why don't we use this to help? And a lot of it works, right? Like I said on page 1294, it talks about the risk for pancreatitis with your DTP4s and the incretin mimetics. Be aware of that. Weight loss can occur with several of these different meds, which is a good thing for some people because you get this satiety, all right? Make sure your patient is aware, of course, that these meds are not insulin. That is not what they are. And like I just said, some of these meds are combinations, like Metaglip is one, metformin and glyphosate, stuff like that. All right, now the fun bit, insulin. You are going to get questions on insulin. All right, you are going to get questions on insulin, just letting you know. So on page 1295, we have a lovely table of the different types of insulin. You've got your rapid acting insulins, your short acting, which is your regulars, your NPHs, and your long acting insulins as well. And of course, they have different effects. Now, what I really want you to know or attempt to learn is these pieces, onset, peak, and duration. You are going to have some questions on that in this exam. You know, a patient might be taking a rapid acting and also an NPH, and you need to know when is it going to peak. The reason I hate NPH is because look at that. I mean, really, really look at that. Look at NPH. Can anybody see what I have a problem with? Why I have a problem with NPH? And why I don't like it being used? What do you think?
You're talking about the intermediate?
Yeah. Look at the onset, look at the
Yeah,
peak.
because it takes too long to onset, and then it takes too long to get to the peak of it.
Well, you know, it's not a rapid acting insulin. I get that. I get that. But look at the range. I mean, we've got anywhere between, you know, look at NPH Humulin N. No, yeah, look at it. So Nova, let's look at Relion. Wonderful Relion, cheap as dirt. You can get it from Walmart really, really cheaply. Great, that's great. What do you think a lot of these patients are having a problem with? I mean, look at it. You've got an onset anywhere between 1 and 4 hours, and you've got a peak anywhere between 4 and 14 hours. Then you've got a duration anywhere between 10 and 24 hours plus.
That their blood sugar's dropping at all different times.
Well, you know, I mean, okay, it's doing what it needs to do, but there's a massive range there. That's my point, okay? That's why I'm not too keen on NPH. It gets used all the time in endo. For people that can't afford anything, they stick them on NPH because it's cheap. But I have a problem with it. I'm just getting on my high horse about it. And I have other reasons as well that, you know, but anyway, NPH to me, and I hear it firsthand from my husband who used to be on, he says NPH is awful. It's such a roller coaster effect for your diabetic. So I'm letting you know what they think. This is what they think. All right, so what are we trying to do really? What would be the best thing that we could really do for our patient? Well, try and replicate what's going on in the pancreas. So what did I tell you? The pancreas is always secreting a little bit of insulin, right? A tiny little bit of insulin. What do we call that? Basal rate. Yeah, that would be your long-acting insulin. And then you eat Prandor and you have a short burst of insulin 10 minutes after you've eaten. So really the best way that we can try and mimic that is to mimic that. That would be the best thing, quite frankly. So it talks about it a little bit here. Starting doses of insulin, usually anywhere between 0.5 and 1 unit per kilogram of body weight, okay? For their total for the day. Basal insulin usually is 40 to 50% of what the patient's going to need, and then they're going to make up the rest with these short bursts of insulin in between. Okay, basal insulin, that's our long-acting insulin. So things like Lantus, Tresiba, love Tresiba. I'm so happy when I put somebody on Tresiba and I did that and his blood sugar came down beautifully, beautifully. Anyway, Levemir, those are the types of things that are your long-acting insulin. And then you have your rapid-acting insulin, right? Bear in mind, these long-acting insulin, are you going to give them more than once a day, usually?
No.
No, usually once a day, right? Some of them, by the way, like Tresiba, just FYI, can last, as it shows you right here, can actually last for 2 days, which is wonderful for the patient. You think about it, they're only themselves maybe, you know, not as much, and it might be a cost saving to them if they're actually only having to do that once every 48 hours. Yeah, so bear that in mind. So then we're looking at our combo of our short-acting insulins, right? Our regular insulins, those are the only ones that you're going to give IV, remember? And then, of course, you've got your rapid-acting insulins, your Novolog, your Apidra, Afezra, Humalog, on and on. There's a lot of different ones there. Bear some of those names in mind because your question may say something like the patient is on Apidra. So you need to know that that's a rapid-acting insulin. How rapid? How rapid is it? Shows you right there, half an hour. Pretty darn rapid, right? It's going to peak pretty quickly as well. So bear these things in mind. I would really look at these pages carefully. Insulin absorption. Well, the injection sites are on page 1295. They can inject in many, many different places, right? And be aware, scarred sites often become favorite injection sites because they're less sensitive to pain. But the problem is they've got this buildup of scar tissue there, so it can slow the absorption of insulin, all right? It's subcutaneous. Somebody little like me, you may do it at a 45-degree angle rather than a 90-degree because I don't have a lot of fat, but usually it's a 90-degree. On page 1296, it shows you some little pumps. I was hoping that my husband was here. I don't know where he is, but I was really hoping he was here that I could show you the pumps. If he shows up, I'll try and show you. All right, what are we going to do with this insulin? When are we going to give it? It shows it right here. Give it within 10 minutes. The rapid-acting insulin is given within 10 minutes before mealtime, all right? When blood glucose is in the target range, so it talks about it. Regular insulin is given within 20 to 30 minutes before eating. And of course, mixing insulin can change the peak time. You know, you may have a combination of the different insulins. Now, bear in mind, safety alert, do not mix any other insulin type with insulin glargine, insulin detamir, or any of the pre-mixed formulations. Two complications of insulin therapy. Well, I mentioned one of them yesterday, but I'm going to mention two of them. You've got two conditions of fasting hyperglycemia in addition to lack of insulin. At the bottom of 1296, two biggies. The dawn phenomenon. So our good old adrenals, they're still functioning, right? So our adrenal hormones, remember the adrenals create cortisol to be released, but they also create glucose to be released. This is why when people are stressed, their blood glucose goes up. All right. So blood glucose elevates with this dawn phenomenon between 5 a.m. and 6 a.m. So what we might have to do is we may have to look at that and say, we're going to have to increase our nighttime insulin. And be aware of this, because this is the type of question that comes up in HESs. And also, I don't remember if I put it in mine, but this is definitely something that you might be aware of. So how do you prevent that? It says it is managed by providing more insulin for the overnight period, i.e. giving an intermediate dose, your MPHs, you might give it at 10 at night rather than at the evening meal. You might give it a bit later. The Somogyi phenomenon, and I talked about that a little bit yesterday, is that morning hyperglycemia, because what's happened in the night is they've become hypoglycemic, they've dropped, and they've had to basically give themselves something to help with that, and then they've overshot it, and then they've got this rebound effect going on, all right? So bear that in mind. I'm not going to talk too much about pumps, just be aware of them. A lot of the time now, our type 1s tend to have the pumps, and type 2s if they get to the point where, of course, they're not producing any insulin. So just be aware of that. Be aware of the fact that it's usually a short-acting insulin or a rapid-acting insulin. Usually it's a rapid-acting insulin because they give themselves a bolus. Okay. What else do I want to bear in mind? Ketoacidosis. Obviously, different types of problems with these pumps can occur. Giving themselves too much insulin can occur. Infection can occur. They must be able to operate the pump. There's a lot of knowledge that goes into operating these pumps. It's, you know, they have to try out different things that work for them, understanding carb counting, and we'll get to that in a little bit. Insulin storage and giving the insulin. Remember in your NCLEX book, it has the description, and also your clinical companion, it has the description of how to draw up your clear and cloudy insulin, right? You know those steps? Do you remember those steps? Can anybody tell steps? Draw up your clear.
Before you're cloudy.
Yeah.
Clear before cloudy.
Yeah. But let me just get my NCLEX book for you, because I want to make sure you guys. Remember yesterday, chapter 50 in your endocrine book, I think. Well, actually, chapter 50 is lovely. I really want you guys to look at chapter 50 because it talks about the different types of endocrine diseases, that we only touch on in the chapters are diabetes insipidus, SIADH, Addison's disease. It shows you a picture of Cushing's, shows you a picture of somebody who's hyperthyroidism, shows you the differences between all that. So I would definitely read this chapter. Talks about dawn phenomenon, Somogyi effect, insulin pumps. Remember, it has a nice side-by-side of what I talked about, DKA and HHS, remember, on page 641. The other thing, it was, where was it? I know there was a, bear in mind. Chapter 51. Yeah. Chapter 51, page 662. You can either look at this, where it talks exactly about injecting your air in your MPH, injecting your air into your regular insulin, because remember, it's a dose, right? So whatever dose it's going to be, and then you're going to invert your regular insulin, draw up your regular, take that out, and then draw up your MPH. So it talks about it right there. But in your clinical companion module, there is a lovely video about that as well, if you need to watch it. You need this. It will probably be on your test. All right.
Thanks.
So, and chapter 51 is a very nice chapter talking about different medications. It talks about endocrine meds. All right. So, NPH, remember you roll it to mix it. You don't shake it, right? Roll it, gently rolling it, those types of things. It talks about the fact insulin should not be allowed to freeze. Usually you keep it, you store it in the fridge. That would be the main way that you do it. It does say insulin can be kept at room temperature for 28 days. And that reduces injection site irritation from cold insulin. And remember now that insulin is not derived from animals as it used to be. It is a recombinant DNA. So just be aware of that. So it's a little bit more stable than it used to be. So be aware of that too. The pens, obviously we can give insulin by syringes, and they're the U100 or the U50, different types like that. The U100 is 1 ml, the U50 is half a ml. I don't really ever see the 30 mils being used. I don't recall ever seeing that being used, but maybe for babies, but it's a third of a mil. Pen type injections, of course, have got the pre-filled with cartridges. They're easy to use, but again, remember your older patient may not be able to read the little dial very well, so just be aware of that. Meters, we talked about meters the other day, right? And making sure that our patients have their meters, have their test strips, all of those things. And helping them get to the resources that they might need if they can't get a hold of their test strips or meters or anything else, okay? Frequency of testing, that varies. Let's see. The ADA recommends that patients with type 1 aim for an A1C of less than 7 and post-meal glucose less than 180. Talks about page 1298. Infection control. Be aware with these monitors that hepatitis B can survive in a dried state for at least a week. So cleaning these monitors are a big deal. What else do I want to point out about that? I don't think I need to. I think you guys are used to doing blood glucose monitoring, right?
Mhm.
Nutrition. Yes, a couple of things I want to bring out with the nutrition. First of all, I want to point out to you, adults with diabetes are recommended to consume at least 25 grams of fiber a day. Avoiding, of course, sugary things. The diet focuses on quality of fat rather than quantity. We're looking at Mediterranean diets, okay? Omega-3 fatty acids, EPA, DHA, I'm sorry. Alcohol, tell them to reduce their alcohol consumption because it converts to sugar. Pretty self-explanatory. Carb counting on page 1300. This is actually really important. They need to carb count. They need to understand that it's a formulation of 1 unit of rapid acting insulin to 15 grams of carb. So that's the ratio, 1 to 15 right there. Okay. So of course, if they're 30 grams of carbs, they're going to have 2 units, right? They need to learn how to carb count. And there's lots of apps that they can use for carb counting. I think MyFitnessPal, things like that, have them. Be aware as well of exercise can cause hypoglycemia if the insulin is not decreased before activity. A lot of them need to actually turn their pumps off. All right, things of that nature. Let's see. What else do I really want to talk about? I'm looking at what I've highlighted here. Oh yeah, this is another piece. Remember I talked about earlier my thing that I don't think a lot of people talk about, which is autonomic neuropathy. Remember I talked about cardiac autonomic neuropathy. On page 1301, halfway down, adjustments for diabetic complications. So be aware that there are a few things that can be an issue for these patients. Many things. First of all, if they have diabetic retinopathy, they may not see as well. Teach patient with retinopathy to avoid the Valsalva maneuver. Why do you think that is?
So they don't fall.
You don't want to increase intraocular pressure. That makes sense?
Mhm.
Yeah. Yeah. You know, halfway down, it says about this, it talks about, you know, you don't want them doing too much heavy lifting. Again, you're looking at the retinopathy, those types of things. Peripheral neuropathy, be aware of their feet, and of course their hands as well. Autonomopathy, be aware of they have impaired temperature control, and develop postural hypotension and impaired thirst. They may not be aware of their thirst, so they can become quickly dehydrated. And what can that lead to?
Potassium problems.
DKA, right? Yeah, and potassium problems, absolutely. So you can see how everything goes hand in hand. Exercise, their blood glucose needs to be at least 80, but less than 250. Okay. They should be aware of their of the potential for ketones. I don't really know that many diabetics that check their ketones anymore, but you know, it's something to be aware of. Ketones indicate that the current insulin levels are not adequate, and that exercise would actually elevate the blood glucose levels. All right, hyperglycemia. Hyperglycemia happens in the hospital for many patients. Glucose isn't regulated, illness, different things of that nature. And then, of course, hypoglycemia. It says here, hypoglycemia is defined blood glucose levels values lower than 40. Whoa, that's an independent for mortality. Yeah, if it's down to 40, they are in deep, deep problems. All right, that's critical. Let's see, what else? Continuous IV insulin solutions are the most effective for managing glycemic control in the ICU. I know Alicia said she's seen this many times, right? Regular insulin. Prevention of hypoglycemia is also partly managed by blood glucose levels, and many facilities have protocols that direct staff to provide carbohydrate replacement if the patient is alert and able to swallow, or administer 50% dextrose IV or glucagon by sub-Q injection if the patient cannot swallow. There is confusion about whether to give or hold insulin if a patient is MPO. It says it right here. Administration of rapid acting or short acting insulin as well as amylin or incretin mimetics will cause hypoglycemia if the patient isn't eating. So what they're going to do is they're going to do a basal rate insulin normally. That controls the baseline glucose levels, but they're not normally going to do the other types of insulin. I'm not going to go into too much about pancreas transplantation, but just be aware, of course, just like any other transplant, the risk of rejection, and of course, needing anti-rejection medications with that, okay? And of course, pre and post-operative care, just like any other pre and post-op care. So I'm really not going to go into that. Talks about metformin stopping at least 24 hours before surgery, but metformin, as we know, can have effects on the kidney, so it's usually stopped for any type of procedure, just in case it harms the kidney. All right. Hyperkalemia and hypokalemia. We talked a lot about that the other day. Don't think I need to go into too much detail about that, right? Or do I?
No.
Okay. Patients requiring clear or fluid, full liquid fluids, they need about 200 grams of carbs, by the way. And initial liquids should not be sugar-free. This is when you're building somebody up from an MPO process, okay? When oral foods are tolerated, they need to eat between 150 to 200 grams of carbs to prevent hypoglycemia. And it talks a little tiny bit about TPN as well, total parental nutrition. Charcot foot is a type of diabetic foot deformity. There's a picture of it there on page 1305. I don't see these anymore, actually. And I wonder if it's because there's a lot more preventative care now. But anyway, it's a foot deformity right there. And just be aware of what it's called and what it looks like, okay? Foot ulcers, again, these patients with neuropathy, they may not even be aware that they've got an issue on their foot, right? And unfortunately, that can lead to a foot ulcer. And it talks about where it is. It can be normally under the great toe, on the sole of the foot, all right? And it talks on page 1305, foot risk categories. So what are we going to tell these patients to do? What would be one of the preventative things?
Wear shoes.
Oh, yes.
Proper shoes.
Yes, yes. What about podiatry?
Go to the podiatrist. Proper hygiene.
Yes. Yes. What do they do at the podiatrist?
From their nails.
Nails, any kind of ulcers on their feet, any kind of calluses they take care of, so nothing builds up and can cause an
Yeah.
infection.
An infection. And they also check for what? Monofilament testing, right? Anybody?
I don't know what that is.
Well, in funds, I think you touched on it, but basically monofilament testing is, you know, they'll get the foot and they'll, on the sole of their foot, they'll touch little tiny, basically monofilaments, and it's like little bits of nylon, and they'll press on the foot to see where there's a deficiency. Okay,
Right.
so monofilament testing is what is done. All right. All right. And it talks about it on page 1305, 1306. And you brought out about foot care, footwear, and on page 1307, it goes into great detail about foot care instructions. I would say this is a biggie because what are we trying to do? We're trying to prevent an amputation, aren't we?
Yes.
You know? Okay. Some of the pain meds that can be used, things like gabapentin, GABA, right, neurotransmitter, Lyrica, pre-GABA. Tricyclics are sometimes used as well for neuropathic pain. I know a lot of patients do not like these meds at all, quite frankly. There is a cream, capsicacin cream can be used. It's from a pepper, hot pepper. That can be used for neuropathic burning. The other thing we're going to teach our patients is eye exams, of course, right? Ophthalmology, proper eye exams. And it talks about making sure that these pre-filled syringes of insulin, that our patients know what to do. I told you what happened with my dad, didn't I? Actually thought he could take one of these off, the end off with a pair of pliers. Yeah. They sent my dad home on NPH, by the way. He ended up back in the hospital within 24 hours. Yeah. So I have a real issue with a lot of these ways that we don't take care of these patients are fragile patients. Insulin is not to be played with, which is why you have two people check insulin, right? All right, helping the patients to understand the difference between fast acting and slower acting insulins. We may have to put colors on them or something so that they know what's what. So on page 13, please look at this for your older patient, so to help them understand the differences between different insulins. Let's see, what else? Kidney disease, like I told you, obviously a BUN, a creatinine, a microalbuminuria. Talks about it right there. GFR, glomerular filtration rate, we're going to check. Anything less than 50 is an issue for the glomerular filtration rate. On page 1313, it shows a lovely breakdown of the lab findings, by the way. Hypoglycemia. We've talked about it ad nauseum, but I'm going to say it again. If the glucose level goes below 70, that's when that patient's going to start getting the symptoms of the sweating, the irritability, the tremors, the tachycardia. Sort of, it's basically a neuroglycopenic type of symptoms. All of these autonomic symptoms go into effect. You know, the body starts to shut down. So of course, it's like this fight or flight reaction that happens, right? And it's basically triggered by the autonomic nervous system. So What are we going to do? We want to get them glucose on board to help the brain. Okay. Let's see. It talks about it, basically just what I just said. On page 1309, it talks about epinephrine. Epinephrine becomes important in patients with diabetes who are deficient in glucagon. Glucagon and epinephrine raise blood glucose levels by stimulating liver glycogen. So please be aware that type 1 disrupts the body's response to hypoglycemia. Often they just don't have a lot of awareness that they're becoming hypoglycemic. Okay, that epinephrine response becomes dulled a little bit. So unfortunately, what happens is the body may not respond to that 70. The body may not respond until they're a lot lower than that. And of course, that can become an medical emergency. Okay. So like I just said, hypoglycemic unawareness can occur. But I would say a glucose less than 70, and on the top of page 1309, it shows you the differences between hypoglycemia and hyperglycemia, signs and symptoms, and also the glucose levels. Okay. How are we going to manage them? What are we going to do? There will be a question on this. Page 1310. Well, actually, these two pages. So mild hypoglycemia, when somebody like me is getting hungry, shaky, and irritable right now, but thankfully I'm still fully conscious. If the blood sugar is less than 60, you're going to give them some 10 to 15 carbs, glucose tablets, juice. Talks about it right there. If it's moderate, I'm surprised they talk about moderate less than 40, because quite frankly, 40 is really low. Okay. I mean, seriously, if they're getting down to 40, they're probably on there, they're becoming unconscious, I would think. But anyway, hopefully you can still get something in them. Hopefully they're still able to swallow. Okay. When it's getting to severe, they talk about severe as 20, and that's when you're going to give the glucagon if they're unconscious or unable to swallow. Anybody ever seen somebody like that or managed?
Isn't it this stuff that you can put underneath their tongue? It's like a toothpaste too.
Yeah.
If you can't get them to swallow.
True. Yeah. It's a liquid.
Yeah.
But remember, if they can't swallow, what's the concern?
Well, that they'll aspirate.
Thank you.
But I thought that just goes in their mouth, that they won't aspirate if you put that toothpaste stuff in them.
I mean, there's still a risk.
It's the glucagon, I think. Right?
Mm-hmm. Yeah. Yeah. So, all right. Okay, so it talks about it right here, what we're going to do for them, the glucagon gun, IV dextrose. Okay, those are the things that you're going to do. And again, I'm repeating it and repeating it, repeating it, and repeating it for a reason, because it's probably going to show up on one of your exams. What's the first line therapy for treating severe hypoglycemia, subcutaneous or IM glucagon? So IM glucagon or IV dextrose, okay, if they can't swallow. Let's see. Teach them to wear a medical alert button, bracelet, those types of things. DKA. I talked a lot about DKA the other day. I think we sort of basically went over that, right? The difference between DKA and also HHS, and that beautiful little side by side on page 1313, but your NCLEX books as well. And remember, really, DKA is more your type 1, HHS is more your type 2, DKA is more your sudden, HHS is more your gradual. And remember, you're not going to see ketones with your HHS. Why? Anybody can tell me why?
I thought that you,
They're not
They're dying.
dehydrated.
yeah.
They're not as dehydrated.
Well, they're dehydrated, but the issue is they're still making most of them a tiny bit of insulin. So that's why it's not really enough, but that's what's going on there. Okay. All right. So what are we going to do for these DKA patients? Well, what did we talk about the other day? You tell me.
Regular insulin.
Right. And what else?
And the fluid.
Thank you. Fluid volume. Okay. And often with the HHS patient, that's all that's needed. Fluids first. Okay. But of course, DKA, they got to have insulin on board, regular insulin. Okay. Hypotonic fluids, by the way. And then we can switch to something like D5 half normal saline once that blood glucose comes up to what? Or down to what? When their blood glucose to about what? When are we going to switch to D5 half normal saline?
At least 250.
How much is it? 250. Okay.
Mm-hmm.
I couldn't remember if it's 150 or 250.
250. Yep.
Okay.
Yep. Going to manage the patient watching for fluid overload, those types of things. Obviously, it's metabolic acidosis. That's what's going on, right? Talks about how much insulin we're going to give here. Just be aware, it'll be an initial IV bolus of 0.1 units per kilogram. And then it's going to be an IV infusion of 0.1 unit per kilogram per hour. Okay. Talks about the ion gap. And I don't really talk about that much, but the ion gap, usually we want it between 10 and 12. Anything greater than that is an indicator of acidosis, metabolic acidosis. Let's see. Bicarb, we only give that if the acidosis is severe. You give that IV. Talks about the differences between HHS and DKA. HHS, normally the blood glucose level is in the 800s. It's higher. One thing I want you to be aware of, it says at the bottom here, unlike DKA, patients with HHS may have seizures and reversible paralysis. Also, patient-considered care. HHS occurs most often in older patients with type 2 diabetics, many of whom are unaware they even have diabetes. So HHS is they may be really, really critical by the time they get to see you. So bear that in mind. On page 1315, there is a very nice flow chart looking at basically what can occur with basically the pathophysiology of HHS. So it just sort of shows you the breakdown of how that can occur. So just bear that in mind. I am just looking to see. I'm almost done, guys, and then we're going to have a break. Again, what are we trying to do with HHS? We're increasing blood volume, so we're using same. Okay. Talks about how much fluid to give. You know, you're actually going to infuse fluids at 1 liter an hour. Wide open. Okay. On page 1315. I don't think there'll be questions, but I just want you to be aware of it.
My
One of the
question
big-
for you is
Yeah,
that the doctor's going to give that order before we can give that, correct?
absolutely.
Okay.
Yeah, but be
So
aware
it's
that
not like I have to remember that. I'm like,
no. What I want you to be aware of is, okay, so we're giving 1 liter an hour. That's a lot of fluid, right? So what can happen? Fluid overload can happen with
Okay.
patients. So we're going to be monitoring for things like cerebral edema. We're going to be monitoring them for heart failure, all right, pulmonary edema. Those types of things could be occurring if we're giving too much fluid. all
So
right?
if you were working in the hospital as like a hospitalist, you could give the order for that because you're a nurse practitioner.
Correct. Yes. Absolutely. And then of course, once, let's see what else I want to mention to you. So once you've got this fluid under control, then you're going to give slow and steady fluids. I think it's pretty self-explanatory, quite frankly. Look at their level of consciousness, pupil reactions, and obviously concern for seizures. That's the biggie with this HHN. IV insulin may be given, usually is given, I'm sorry, once the fluids have been replaced. And again, it talks about the 0.1 unit per kilogram per hour. And then when the blood glucose gets to 250, we're switching them to D5 half normal saline. Okay. The other thing we're checking for a lot is, of course, potassium. Right. Now, the last couple of pages talks a lot about self-management and survival skills information. Sort of cracks me up. It cracks me up because my dad didn't get any of this, but sorry, I'm getting on my high horse. But, you know, as we've gone through this whole chapter, you can see how much needs to be learned by these patients. I mean, my goodness, so much information that we throw at them, right? So there really has to be an interprofessional team, including your social worker, your diabetic educator, your home care people, your pharmacy, nurses, physicians, dietitian, everybody involved in this patient through this.